were asked today to come and talk, kind of give like a little brief overview of clotting cascade, common anticoagulants and where they work on the cascade, and then we'll talk about perioperative management of the anticoagulants and then emergent reversal of those agents. So this is the clotting cascade. It's kind of a more of a basic overview of the cascade. There's a lot that goes into it. I'm not going to really talk like super in depth because I could probably talk the whole time about, well, I probably couldn't, but somebody could talk the whole time about the clotting cascade. But the basic things to know is that there's two pathways. There's the extrinsic pathway and there's the intrinsic pathway. Both pathways eventually lead to the same thing, which is prothrombin to thrombin, and eventually leading to clot. So the extrinsic pathway starts with tissue factor when there's tissue trauma, and that basically, in the most basic of sense, causes 7 to 7A, and then with 7A causes 10 to 10A, which then leads to the prothrombin activator, which then it leads to clot. On the intrinsic side, that's when there's trauma to blood cells directly, or blood cells are exposed to collagen, and that leads to factor 12 to 12A, and then that causes 11 to 11A, 9 to 9A, which then causes 10 to 10A, and then it's basically the same thing from there. The most important ones that we are going to talk about would be factor 2, which is prothrombin to 2A, and that's basically what's causing us to clot at the end. So this is kind of where both pathways lead, which is the prothrombin activator, which causes prothrombin to thrombin, and then thrombin causes fibrinogen to fibrin, and then fibrin turns into fibrin mesh, and then it attracts fibrin stabilizing factors, and then eventually forms a blood clot. So these are some of the more common anticoagulants that you're going to see. I'm not going to talk about dosing. This is just how they're available. There are other anticoagulants as well, but these are kind of your more common ones. You have your oral novel anticoagulants, which is your apixaban, dabigatran, edoxaban, and rivaroxaban. Apparently I left off. And then your enoxaparin and fondaparinux, which is your low molecular weight heparins, and then heparin, and then warfarin. So on that same clotting cascade, this slide shows kind of where everything works. So apixaban, edoxaban, and rivaroxaban are your 10A inhibitors, so that's primarily where they work. Those are probably the most popular ones to use right now for anticoagulation because they work in one spot. They don't have as many drug interactions, they don't have as many food interactions. The half-life is pretty straightforward versus your other one that you used to see, or you still do see, orally is warfarin. Warfarin is a little bit more complicated because it works at 2, 5, 7, 9, and 10. And because of the different half-lives of all the different clotting factors, that's why it takes time to work in the body and it takes time to get out of the body. So that shows you where those work. And then your heparin, enoxaparin, and fondaparinux. Where, just so you probably know, but enoxaparin and fondaparinux are similar, but fondaparinux has a special ability that it can be used in patients that have heparin-induced thrombocytopenia. So here, that's really where you're only going to see it used. It's not going to be commonly used unless the patient has a history of HIT, right? So as far as perioperative management of the anticoagulants, obviously you're basing it on their risk assessment for bleeding versus having a clot. Some patients do require a bridge when they're off warfarin. So this is primarily for warfarin. Reasons that we do bridging with Lovenox would be for AFib if they have a higher CHADS-VASc score, or if they have a history of an embolic stroke or some other systemic embolic event within the previous 3 months. If they've ever had a clot before when they've been off of warfarin for a procedure, you're likely to bridge them with Lovenox as well. If they're a mechanical mitral valve, or if they're a mechanical aortic valve and they have additional risk factors, or they have recent stenting. So as far as stopping warfarin, generally if the surgery is planned, we're going to stop the warfarin for 5 days before the surgery. Usually there's a goal liner of less than 1.5. Sometimes it's checked the day before, sometimes it's checked the day of, depending on the procedure. Sometimes for higher risk procedures like epidurals and things like that, they would stop longer. Usually warfarin can be resumed within 12 to 24 hours after surgery because again it takes time for the warfarin to get back into the body. So if you're bridging with heparin or low molecular weight heparin, you're really only going to see heparin if they're inpatient because it has to be a drip if you're going to use a full dose of heparin. You want to stop heparin 4 to 6 hours before the surgery. If you're bridging with Lovenox or enoxaparin, you're going to do the last dose 24 hours before surgery. And then you can resume the enoxaparin 24 hours after surgery if it's not a high bleeding risk, longer if it is a high bleeding risk, because again, that has an onset right away. As far as the newer anticoagulants, we don't typically see them bridged with anything because they have, the offset is faster. So usually it's 2 to 3 days or 2 to 4 days for most of them, and then they can be started 2 to 3 days after. There's not really a clear-cut guideline. Again, these are newer drugs, so there's just not as many studies with them. And it does depend a little bit on their renal function, what their dose is, their age, the surgery, and all that as well. So obviously, it would be nice if all of your patients had planned surgeries, but a lot of them don't. So Candace is going to talk about what we have to do in emergent cases.
So the most common indication for reversing anticoagulation emergently is active major bleeding, and that's defined by the American College of Cardiology as meeting one of 3 criteria. So the first is bleeding at a critical site, and critical site bleeds are defined as those that compromise the organ's function. So most commonly intracranial hemorrhage or other central nervous system bleeds like intraspinal, intraocular, also thoracic, intra-abdominal, retroperitoneal, intra-articular, and intramuscular. Those are considered critical just because of their capacity to cause disability, and they often will require surgery to return the patient to hemostasis. GI bleeds are not considered critical site bleeds, but they can often cause hemodynamic instability, which is the second criteria. And then the third is overt bleeding that decreases the hemoglobin at least by 2 points or necessitates administration of at least 2 units of packed red blood cells. And then some other indications that are less common in practice, elective or emergency invasive procedures or surgery or over anticoagulation. Generally don't reverse these patients unless there is bleeding associated with these situations or in other special circumstances, like if their surgery can't be postponed for any reason. But in all cases when you're going to be emergently reversing someone, you want to weigh the risks and benefits of reversal, so the risk of bleeding and the damage that bleeding can cause versus developing or expanding the thrombus. So this is kind of a summary of the emergent reversal agents that are used to reverse specific anticoagulants that we're going to go through in detail in the coming slides. So we're going to start with emergent warfarin reversal. So as it is a vitamin K antagonist, vitamin K is the antidote for this medication. This is the true antidote, whereas other products that are used in this setting are really temporizing measures to help control bleeding or replenish the coagulation factors. So for patients who would meet one of the criteria for emergent reversal with an INR greater than their goal but less than 4.5, if they're not currently bleeding or having non-major bleeding, it would be appropriate to just hold the warfarin dose or just reduce the dose until they're therapeutic. But if for some reason you wanted to correct it more rapidly within about 24 hours, you could consider giving vitamin K orally at 2.5 milligrams. And then for a higher INR, 4.5 to 10, if they're not bleeding or having non-major bleeding, vitamin K orally at that same dose is indicated. And then for an INR above 10 with no bleeding, vitamin K orally at 2.5 to 5 milligrams is preferred, but you could consider giving it IV at the same dose. And then for active bleeding, you'd want to give it IV over 30 minutes.
Just a question, why is the oral preferred over the IV for an INR greater than 10?
If there's no bleeding, It's just, I think that's,
Is it
it's not
cheaper?
necessary to give the IV.
Is it a cost thing?
It's not a cost thing. For the most part, it's more that you can have anaphylactoid-like reactions with the IV. So we generally don't give things IV unless we have GI absorption issues or, because it's just as effective orally as it is IV. For
I mean, in
IVs, we'll
time,
get
how,
faster.
in terms of how fast does the oral kick in versus IV?
Probably a few hours slower. So again, if you're not bleeding.
So it's a difference of a couple of hours?
Yes.
Okay. I think that's what Dr. was saying.
And both of them, as far as the vitamin K administration, it's gonna continue to work, so you're gonna maybe have to work a little bit against it when you're trying to come back after, you know, a couple days after, if you're trying to restart your warfarin, it's gonna take some time. Yeah, long half-life.
And then for major bleeding, no matter the INR that the patient has, you're going to want to give vitamin K IV at a higher dose of 10 milligrams over 30 minutes. All right, and then prothrombin complex concentrates are the agents of choice, first line for treatment of patients with major bleeding due to warfarin, and it's always given with vitamin K. So there's a couple different products on the market, but they all contain highly concentrated coagulation factors. There are 3-factor products that contain factor 2, 9, and 10, and then the 4-factor products additionally contain factor 7. And the 3-factor products are less effective, generally not recommended, so the 4-factor are preferred, and then those are additionally classified into inactive or active based upon their factor 7 component. So the active has factor 7, activated factor 7, but inactive for all the others. These products are contraindicated in patients with a history of HIT, and then PCC products do have higher factor concentrations than FFP, 25 times greater, so they are a lot more effective in reversing anticoagulation due to warfarin.